Let's bring up Dr. Ellen Elias. She is one of the well-known heroes to all of us who have been supporting people with Smith-Lemli-Opitz syndrome. If I read her entire biography, it will take too much of her allotted time. Let me say that she's a full professor of pediatrics and genetics with tenure at the University of Colorado School of Medicine, where she directs the Special Care Clinic at Children's Hospital Colorado, the largest clinic of its kind in the United States, where children with medical complexity receive both primary care as well as coordinated consultative care for their genetic, medical, and developmental disorders. She was one of the original geneticists to discover the cause of Smith-Lemli-Opitz syndrome, and she continues to pursue clinical research regarding the care and management of patients with this disorder. Ladies and gentlemen, Dr. Ellen Elias.
Good morning, everybody. It's such a pleasure for me to be here today. I've been on this journey caring for patients with SLO for now 30 years, since 1993. And I need, what did I do with the thing? Thank you. So let's see if I can figure this out. Dr. Steiner gave you a very nice brief history of how the cholesterol defect was identified. And I just wanted to highlight a couple of things. It was 30 years between the time when Drs. Smith-Lemli and Opitz first described 3 little boys with SLOS, and working with my partner, Dr. Mira Irons, and a group of chemists in New Jersey. We identified this error in the final step of making cholesterol in your body. It was the first disorder in humans in this cholesterol pathway, which is a very complicated pathway. And since subsequently, a number of disorders have been identified in this pathway that have some similarities to Smith-Lemli-Opitz, but SLOS is by far and away the most common and also the most mild. Our initial patients in Boston, there were 4 of them, were identified to have very low cholesterol levels. They also were quite on the more severe end of the spectrum, with very severe feeding problems necessitating feeding through gastrostomy tubes. So the patients were really not able to eat orally, our initial patients in Boston, and pediatric formulas that were available at the time to use through the G tubes had virtually no cholesterol in them. Very little. You know, at the time, cholesterol was thought to be a kind of a bad thing. It made you have bad heart disease when you were an adult. And there was no such thing as a cholesterol medicine at the time to use. I really struggled to figure out what to do with patients with very, very low cholesterol levels. And it was so wonderful to hear Dr. Haas's talk, because I think we have many similarities in our approaches to caring for patients with SLO. The one difference is I don't use simvastatin at all, but many of the other things she said have been similar to my approach as well. The other problems that I ran into from formulas just not having any cholesterol in them was the fact that many of my patients had multiple food allergies, including egg allergies. So when people are allergic to eggs, they're mostly allergic to the white part of the eggs, not the yolk itself. But if we're using eggs as food, it's pretty darn hard to just get the yolk out and not have any contamination with the white. So my patients with severe egg allergies were just not able to be treated with egg at all. So as you've heard earlier today, and what we discovered really due to Smith-Lemli-Opitz is how important and critical cholesterol is in your body in many ways. And we did not know this in the early 90s. All of this information arose and evolved because of what we learned from patients with SLO. And I'm very, very grateful to all of my patients over the years who taught me so many things. But cholesterol is critically important. It makes up 1/4 of the white matter in your brain, the myelin. One of the things I haven't heard mentioned so far yet is the importance of cholesterol in the cell membrane. So every cell in your body and every organ is surrounded by a membrane, and the integrity of that membrane is very dependent by how much cholesterol is in the membrane. So if there's a severe deficiency of cholesterol, then the cells can be very, very unstable, and the membranes can be very misshapen, and that can impact especially places in your body where there's very, very rapid cell turnover, where your body is trying to rejuvenate, places like your GI tract, like your skin, like the back of your eye, the retina. I'm going to be talking a lot more about that tomorrow. But red blood cells can be very misshapen and abnormal looking under the microscope. And so the cell membranes, in my opinion, the deficiency of cholesterol leading to cell membrane instability causes many, many, many different organ system problems. As was mentioned earlier, cholesterol is used as a substrate for certain hormones in your body. So the sex hormones are made from cholesterol, for example. When you do a screen during pregnancy called estriol, that's a sterol. So a woman who's pregnant who has a quad screen might have a really, really low estriol level that's measured, and that's often the first indication that the baby might have SLO. And most importantly, cortisol, a hormone made by your adrenal gland, is made from cholesterol. So when Dr. Haas mentioned this emergency protocol that she has for patients with SLO when they get critically ill, or if they're having a major surgical procedure, we give what is called stress steroids. It's a much higher dose of steroids to the child, because their own bodies, if the cholesterol is very low, is not able to mount the usual response of increasing the cortisol level to help you fight that stress of a severe illness or a surgical procedure. And then bile acids are substances that are made from cholesterol in your liver, and they live in your guts, in your intestinal tract. And bile acids are essential for absorbing nutrients, particularly fats, in your diet. And so if your cholesterol is super low, you cannot make sufficient amounts of bile acids, and therefore that can lead to nutritional deficiency and significant problems with gaining weight and growth. So I just mentioned about cell membranes, and over the course of these 30 years, I have been looking at the skin, the retina, GI issues, and you're going to get a talk online from one of my colleagues in Denver, Dr. Shekha Sundaram, about some of the GI issues that patients can say, and blood cell abnormalities. So how can we take a person whose cholesterol level is 4 or 10 or 20 and raise that so that you have more cholesterol available to do all of these other important functions in the body? So because there was just no cholesterol in the formulas we were trying to use, we invented a cholesterol medicine. And it's been available since 1994. And I was fortunate, one of my cousins is a chemist, and he happened to work for a pharmaceutical company that made pure pharmaceutical grade cholesterol. And we dissolved that in oil, in soy oil, and worked with the research pharmacists at the hospital where I was, and created this medicine. It's very concentrated. It's the equivalent of 5 eggs in a teaspoon. And it's a liquid, so you can put it in a feeding tube. And I have been using that now for 30 years. Eventually, when it was first invented, I had to go through the FDA to get permission to use it. And I used it as part of a research protocol. It's like food, guys, it's cholesterol. But I was issued an investigational new drug number to just, and in my mind, that was good and important because I wanted to make sure that using this new medicine was going to be safe for my patients, that I was not going to cause any harm by this new medicine that we invented. But then over time, and since it's proven to be very, very safe, the FDA told me I didn't need to use it on a research basis anymore. It's made by a compounding pharmacy. So a pharmacy that takes powder and the substrate and puts it together into a medicine. For a long, long time, my pharmacy in first Boston and then Colorado shipped it out to my patients all over the country. More recently, during COVID, some of the rules for that changed. And now what we do with patients who can't get it from my pharmacy in Colorado, we share the recipe for this with local pharmacies all over the country. So I have patients in many, many states who get this cholesterol suspension made locally by a compounding pharmacy. You know, Walgreens has compounding pharmacies. Many of the major pharmacies are compounding pharmacies, and they can make this. And I have had relatively good luck getting insurance to approve this for my patients. A lot of my patients are on Medicaid, and Medicaid approves it in Colorado. For the patients with more private insurance who don't have Medicaid backup, it's a little trickier. So I'm going to talk to you this morning about other ways you could use cholesterol that you can more easily find without using this, my suspension. So I lived in Boston when this was all first coming down 30 years ago, but I moved 22 years ago to Colorado. And so I brought the suspension and my treatments to Colorado. And how we follow patients is I follow the cholesterol and the 7 and 8 dehydrocholesterol levels so I can tweak the doses and make sure that I'm using enough. And I also follow over time kidney function, liver function, and blood counts, because all of these different organs can be impacted by this disease. So what I have seen sounds like similar to what Dr. Haas just told you about, is I've been able to get cholesterol levels up and precursor levels down. I've been able to show improvement in growth rate. And I feel that it's much easier to use a higher dose of cholesterol than one can just get from using eggs alone. So there are many patients who can eat by mouth and eat foods that contain cholesterol. As Dr. Haas mentioned, one egg yolk has about 200 milligrams of cholesterol in it, but there's cholesterol in other foods as well. The liver has a very high concentration of cholesterol if anybody likes to eat liver, but meats, dairy foods, and so on. There was an aqueous water-based suspension that was invented in Baltimore that some patients have used. And then I have very, very creative parents of my patients over the years who have found all kinds of things and used all kinds of ways to get cholesterol in. I had one mom who found a liver extract on the internet and is using that. There is this product that's called liquid whole egg, but if you're looking for liquid egg products online, you have to be careful. It contains whole egg, which has the yolk, right? Because if you're just giving egg whites, you're not getting cholesterol. There are special shakes that some of my patients have made. They'll sort of soft boil eggs to the point that the white is hard enough you can scoop the yolk out of it, and then add the yolk to heavy cream, to milkshakes, ice cream, and whatever kind of flavoring the child might like. And those milkshakes have been very, very well tolerated. back in the beginning, I created a formula called log, which I haven't used in a long time, pretty much because it was so disgusting. But it was one of my patients was on it for about 15 years, and she absolutely did great on it. But it's very laborious to make it. You take baby food jars of lamb. That's the L. You could use beef also. And then you add it to oil, you add vitamins to it, you add glucose to it. So it's lamb, oil, and glucose. Gives you the name log. I have the recipe for that too, if anybody wants to try it. You add all of that stuff to your blender. And you can pour it in the G tube, and it looks brown. It sort of looks like what might come out of your back end if you have diarrhea, and doesn't smell fabulous either, but it works. It really, really works. And then there's the Cholextra that you've seen mentioned by Dr. Haas, which you can also buy online, and it is pure cholesterol powder. So it doesn't have the complication of adding of the sucrose. And I have my slides, which I hope will be available to you all, but that is the recipe for making log. And here is more information about the Cholextra powder. It comes with a little scoop in the can, and one scoop is equal to a little over 300 milligrams of cholesterol. And the advantage, it's tasteless, it's odorless, it's easy to use for patients. So how much cholesterol do you need? I am trying really hard to get cholesterol levels over 100 milligrams per deciliter. Sometimes I can't get them up higher than 50. But my experience with using a similar dose to what it sounds like Dr. Haas is using, between 100, maybe even as high as 300, but I really do that, milligrams per kilogram per day divided in 3 times a day. And the more severe the disease in the patient, the higher the dose I use, because the lower the cholesterol is. And a kilogram, we use pounds here in this country. But if you multiply kilogram by 2.2, you get the weight in pounds. So that's how I calculate how much cholesterol I want to give. Something that's really I've noticed over time is that cholesterol levels in a patient will tend to drop pretty significantly during the stress of a severe illness or a big surgical procedure. And if that happens and the cholesterol level falls really low, it's important to think about giving the stress steroids, because the patient is not going to be able to mount the normal adrenal gland response.
Dr. Elias, I think there was a number of people that were interested in your recipe. You took it down quickly.
Oh, I can, let's see if I can. There it is.
Thank you.
You're welcome. And these are the little baby food jars. They're typical size. People got it? Can I go ahead? Okay. And maybe Gretchen could, whoa, no. Where'd you go? How often do I check cholesterol levels? So, Dr. Steiner mentioned that you only have to do this test once to prove a diagnosis. I think what he meant is the genetic expensive test, like whole exome sequencing. You have that diagnosis, you got it. You don't have to repeat that again. But I think it's important to follow the cholesterol level and the precursors, because that helps me determine how much cholesterol I need to use, because it's different in every patient depending on the child's severity of illness. So what I try to do when I'm first starting treatment is I'll check fairly often. And then once I feel like I've gotten into the right range per the child's weight, then I'll change, then I'll check every 3 to 6 months. And part of that is dependent on how well other things are going medically for the child. Are they growing? Are they gaining weight? Are they having any issues with liver test abnormalities? Are they having any other of the complicated medical issues that these children can have? And so any one of those factors might make me want to check a little bit more often. And then for my study using antioxidants, which I think I get to talk about tomorrow morning, patients from out of state come and come actually physically to see me in Colorado just once a year. But in between, I work very closely with the local physicians wherever the patient is coming from, because I have patients coming from all over the country out to Colorado. But I work closely so that patients don't have to travel a lot, because some of the labs I check, like your blood count, your liver function, your kidney function, your vitamin D level, all of those things I can easily be checked locally wherever a person lives. And then I get that information sent to me so I can keep track of it. So every patient is an individual, not no one is exactly the same. And so what I need to do to follow them is just assess what the needs are and then individualize my care. I want to thank the Smith-Lemli-Opitz Foundation for their incredible work and supporting you all as families, and for all the amazing work that was put into putting this conference together. Just so devoted and so caring. The foundation is. They're just an amazing and wonderful group. I wanted to thank all of my patients for their patience with me over time and teaching me all of the things that I've learned about this disorder, which I would never have known had it not been for my patients calling and telling me, Dr. Elias, Sarah's in the swimming pool. Oh, that's nice. And the mom says, you don't get it, do ya? She's never been able to go outside because she is so sun sensitive. That wasn't known. That wasn't known at all back in the early 1990s, and still until we started her on cholesterol, and then suddenly she could go outside more safely. So I'm going to stop there and see if there are questions.
Dr. Ellen Elias, ladies and gentlemen, let's give her a round of applause. We're just about due for a break, but I'm curious too to see if there are any questions in the room.
Hi, Dr. Elias. Thank
Hi.
you so much for teaching us. My question is your cholesterol suspension versus the other things you talked about. Are those things that parents have tried because insurance wouldn't pay, or just a personal preference? Is there any reason that you would lean towards one of those versus your suspension for a patient?
Okay. So if patients are in the more mild category and are eating foods, I can often get cholesterol in them with food. And not all of my patients are egg allergic. By the way, some are also allergic to soy. And if that's the case, I have to use a different kind of oil to make the medicine in. It's very individual based on the parents' preferences and the child's preferences and what they tolerate. You're going to hear after the break from Dr. Sundaram, who's a wonderful gastroenterologist, and GI problems like frequent vomiting, feeding intolerance, irritability with feeds. All of those things are extremely common in patients with SLO. And so there are ways to help patients and deal with those symptoms and help children grow better. And so I work in my clinic, we care for over 5,000 complicated patients with all different kinds of genetic diseases. One of the most important colleagues that I have in my clinic, I have 5 dietitians. We do a lot of nutritional care and management, and I also work very, very closely with my PDGI colleagues because of all of these difficult symptoms with feeding that patients can have. It can be a real challenge.
There are a
Thank-
few questions online too. Do all bird eggs contain the same amount of cholesterol, such as duck eggs and so forth?
That's a good question. I don't know the data for that. And as Dr. Haas mentioned, the bigger the egg, the bigger the yolk and the more cholesterol is in it. So most of my families would use, large or extra large size eggs instead of the small ones just to get more cholesterol per yolk. But I don't know about other kinds of fowl.
Okay, another question. Do the cholesterol supplementation or growth studies and results include the delta and total caloric intake? If not, why wouldn't they be tracked?
So when we're following growth and the weight of a child who's having trouble growing, we very closely monitor the longitudinal growth over time. And there is now available a special Smith-Lemli-Opitz growth chart, which I think has been very, very wonderful, because if you're comparing a child with SLO on a typical child's growth chart, they're going to look well below. It's very important to look at weight for height, because if you are very, very short, you don't have to weigh as much, right? We want the weight to be proportional to the height. And so that's how we follow kids, looking at weight for height, or something called body mass index, or BMI. And then now that we have the specialized SLO growth curves, I can tell families, well, your child is really growing very normally for a patient with SLO.
Thank you. Another question is the reported improvement in growth and weight related to the increase in cholesterol levels after supplementation, or just a result of the additional nutritional intake from the egg yolk supplements?
Not sure I know that for sure. Okay, but if cholesterol is available as a substrate, then the child is able to make more bile acids, can absorb the nutrients that they're being given. And so you get onto a sort of better cycle of improved nutritional health altogether.
Thank you. Another question. When having cholesterol level 146 over 200 and taking 100 milligrams, when should we start increasing cholesterol dosage over 100 milligrams per?
So the units are interesting, and I'm glad I got that question, because I'll have to go back and see exactly how it was phrased, but I think it's important to mention something, and I missed part of Dr. Steiner's talk. He may have said this, but cholesterol, when you get your cholesterols back when you go to the doctor, is measured in units called milligrams per deciliter. Okay, so most people are trying to not let their cholesterol levels go over 200 or stay, lower than that for good heart health if you're an adult. The lab that I use, which is the lab at Kenny Krieger in Baltimore, part of Johns Hopkins, they report the units of the precursors in micromoles per ml. So it's a different unit, and you have to correct it to see what. I also look at the ratio that Dr. Haas mentioned of precursors to total cholesterol, because in a person without SLO, your cholesterol is 100% cholesterol. But if you have SLO, there's a mixture of the precursors, the 7 and 8 dehydrocholesterol plus cholesterol, and the more severe disease, the precursors can make up 50% sometimes. of your sterol levels. So part of my treatment in getting the cholesterol level up is working on trying to have the liver not work so hard to try to make cholesterol if the level's really low, and in the process just make more precursors. So it's important to know the units where the cholesterol has been measured. Make sure it's measured in a specialized lab, not just your hospital lab. Your hospital lab cannot differentiate between cholesterol and the precursors. It has to be done in a special way. And so I need to know the units, what's been measured, where it's been measured, to answer that question for that family of what kind of dose would I use.
Thank you. And last question is, when you talk about feeding problems, is this after birth and continuing to adulthood? And if so, what kind of therapies can help remedy those situations?
That's a really great question. What kinds of therapies can help with the feeding problems? So in more severe patients, we often end up putting in feeding tubes fairly early on in life during early infancy. For my milder patients, they're just, able to eat and they may be slower to progress in their feeding skills than a typical child would, but they're still able to maintain their weight and grow in a reasonable fashion. There are feeding therapists that I very often refer my patients to. Feeding therapists can be speech therapists, sometimes they're occupational therapists, sometimes there's a feeding team that's composed of speech and occupational therapists, and a dietitian that can help figure out different ways and therapies to help a child feed better. Feeding is a complicated business, coordinating all the muscles in your mouth, inside the swallowing mechanism, so food goes down the right pipe and you don't aspirate. And there can be problems in a patient with SLO related to their low muscle tone and their delayed development, that the feeding skills kind of parallel language development skills, right? So if you learn how to make the sounds, babbling and making words and so on, and that comes along in a fairly reasonable way, then usually those muscles that have to make those sounds work well or okay to help you swallow food too. So that's why a speech therapist is often involved in this process, to look to see what kind of therapies can help both of those things come along.
And lastly, real quick, sorry, Andy, we've learned that you and your husband are celebrating your 46th wedding anniversary in Seattle this weekend, is what I understand. So,
Congratulations.
Thank you very much.
And we will have an additional chance to hear from Dr. Elias on a related subject later in the conference. So you'll have another opportunity to pepper her with questions and ask about her upcoming celebration plans. Meanwhile, it's time for us to celebrate that we've made it through the first portion of our conference with a 10-minute break. And when we come back, we'll hear from some more speakers. Thank you very much.